are what we eat. So, without further ado, let's begin. So, we're sort of going to go through anatomy and physiology, the anatomy in a brief review, and as in, boy, you guys need that. And the physiology lessons. You what?
I'm feeling it today. I don't like digestive.
I also don't like digestive, so I think
We're not having it. This is not a forum.
I know.
let's just skip it.
I'm just not as enthusiastic as digestive.
Throw Bill Nye on the screen.
Right.
Yeah.
Bill Nye
we
science
watch
guy on
Bill
the
Nye.
screen.
Or we can watch the new Mandalorian. It's out right now.
Yes.
I'll log into my Paramount Plus account, or my Disney Plus account. And go from there.
Do we just do it?
No,
Why not? You guys
I would.
have
I
videos.
want to keep this job.
What happens if Grogu eats something? We can say,
We
oh,
will give
digestive
you-
system.
We
Bam.
will give you the best, end of year
Does it-
evaluation.
I don't have to do evaluations this term. You can't use that against me. And 3, I do what I want to do.
Okay.
It gives me a chance to have an occasional humorous anecdote and/or story. I mean, you're talking to somebody here who's talking to you with the most checkered history.
I don't know. Can we just have story time then?
You don't want to hear about what I went through.
Yeah, we do.
No, you don't. You have no idea how sick I was. Oh, it's unbelievable.
Yeah, but what about the fun parts?
I nearly El Croco.
But you're here.
Took the dirt net. 6 feet under.
Gosh, though. That's awesome.
Yeah, I'm like, everybody the same story. My daughter would one day come in and tell you how she, at age 14, threw herself on top of me in a hospital bed and said, "You're not going to be here for my wedding." She's still not married. She's 37 years old. She isn't married.
You gotta get all this, Dr. Stein.
What?
Set her up with Jacob.
Yeah, let's not.
Do you want Jacob as your son-in-law?
He would kill
The
me.
age difference is significant. You're in the wrong direction. You know she likes to go in the older
She's
direction.
not a cougar.
No. You saw her. You saw a picture of her boyfriend.
Yes. Yeah.
He's a nice looking guy.
Yeah.
I mean, his arms are bigger than my thighs.
Oh, yeah.
They go every morning. Look about every morning at 5:30. They're at the gym working out for an hour and a half.
Come on, Jacob. You want to steal?
You're gonna have to get to the gym at 5:30 every morning.
Yeah.
5:30. I go to the gym anyways, but if I gotta go 5:30, Dr. Stein,
Moving on.
I'll get yoked.
So, this is basically, we're going to start now, everybody. I realize, I'm here to remind you, I would never tell tales. I actually had occasion to say nice things about this class to Dr. Hillwood. Don't know why. But but the next test is coming up, and it's not 2 chapters, it's 3. And we've concluded the material. So guess what's coming up? We have to figure out when to have this test.
We just had one.
Right, because we were 2 weeks late having that one.
Whose fault was that?
Take
Your
home test.
assistant.
No, we're not doing a take-home test.
We
Why?
have this exam coming up and a final.
Yes,
Yo! Wait,
Oh.
final's not cumulative though, correct?
correct.
Is it online again?
And
Wait,
online.
if our final can be 2 chapters and this next, the second one can be 3, I think that sounds fair.
But is
How
the
about the
final
fourth one?
Wait a minute.
We don't eat
Thank you.
things.
Yeah, but the final.
Hey Kyle, you're here, let's try to get that here.
Oh, wait. I'm getting text messages.
I'm getting text.
Okay, moving on.
Wait, Scott.
What? Yeah, here, I'm looking at the date. That's why I went to look at my phone, and I had a text I had to get.
Is the final online?
It's the final online, possibly.
Okay,
Don't hit me with the possibly.
Dr. Stein, here's one question.
It is. I just said.
This is in general. For like MCATs, are our finals? Whoa.
So our
We're not doing
finals-
finger puppets here.
Our finals
All right.
online.
It'll be online.
So our finals.
I was going to show that picture to my wife, but I'm not.
What, the
Just to
one
show you how
that's-
nice you guys were. No, I'm not.
Why not? You show it to the puppies, the kitties.
I should,
The assistant knows.
listen to me. I'm looking at, this is important. So we're going to have this exam before we depart. When are you departing for the
I
4th?
believe I won't be here on the 4th.
I'm thinking that we should probably be looking at this test maybe on the 3rd of April.
On a Wednesday?
That's a Monday.
That's a Monday.
Ooh, a Monday test.
God almighty.
How about Alexa takes it Monday, and we don't take it till Friday?
I would love that idea. I'm so
No.
sorry.
Well, yeah, put some energy into thinking about this. We'll revisit this on Friday.
Alright, that's
So you can give it to her while we lecture on Monday. She can go to the lab and take it.
It's possible.
We won't have class on Friday.
That's not the end of the world. But I think you're the only one who's not going to be here. Are you guys around?
We have games the day before. I need to figure out if they're away.
Well, let me know. Fill me in.
What if we did April the 5th?
Well, I'll consider. Yeah.
What if we did it online?
No. I know 1 out of 2 ain't bad.
Okay, so
There was a really good song called 2 out of 3 ain't bad. But
final online, next exam, April 5th.
possibly. Well, I'm taking him under, sir.
I'll actually raise my hand to get into this conversation real quick. So, anyways, so for finals week, is ours, like, when would ours be? I would like it online, but what date technically?
You should have the final exam schedule.
Oh, we do, alright.
Somebody has it.
And then my second question,
Tuesday.
it's Tuesday?
11 to 1.
Janelle, do we have MCATs that week, or are those week 14? Like, do we have MCAT finals?
No, yeah, you do, but we have an MCAT final, but I mean, it's basically a mock MCAT.
Okay,
So, I mean, we'll figure out the logistics of it.
gotcha. Because I was just saying, because if we're done by Tuesday, and I can get home by finals week Tuesday, you'd be a miracle. Because that's,
So,
not not.
what
So,
if we,
if I can get
What?
out here
what if you
Tuesday,
printed the test out, gave it to us, we do it at home,
Oh,
and then we
Sure.
give it back?
You're incorrigible.
Or you just open the exam like you did last semester, from like Monday to like the end of our test time.
No, I'm doing that exam free.
Oh.
For the final, I can play, we're good. This exam is going to be more of a typical exam. The final, it's going to be the opportunity for everybody to,
It's gonna be like our anatomy exam.
get where you want to go.
Okay. I
Just-
like that.
You're going to have to deal with it.
Okay.
Oh, she's such a.
Deal with it.
That's fine.
I'm sorry.
I'm not liking you today. We have beef.
I give up.
You flicked me off.
I had a spasm in my.
Muscle contraction. Involuntary muscle contraction.
Right. We're in. All about the digestive system. We know all this, self-explanatory. You put it in, you process it, you absorb it, you get rid of it. Anatomically, we have GI tract and accessory organs. We talked about that. There's nothing, we're not going to make it an anatomical test. The accessory structures are that. Glands, which we're going to spend a lot of time on with this, gallbladder and liver and pancreas, certainly. You all saw that view many times. The first thing we have to deal with from a functional standpoint is how things move through. And that is basically the propulsion aspect. Remember, it's a tubular smooth muscle structure that operates on stretch receptors, chemical receptors, and osmotic receptors. So variations of that theme. For the most part, it's stretch receptors. It's a tube. As something enters the tube, it stretches it. What do most muscles do when they're stretched? They respond reflexly and push. So it's pushed, and when it does that, it compacts the material and pushes it along, because they typically alternate compressing and then relaxing, compressing and relaxing. We're going to see some variations of that as we go through. Peristalsis is the segmental motion of food in a direction from where it starts to enter from the mouth effectively until it's expelled through the anus. We'll see that. The comment I made at MCAT is we see examples of reverse peristalsis when we do reproductive functioning where sperm are carried from their entry point toward the fallopian rather than out, but in deeper. It's sort of quote unquote reverse, even though it's peristaltic action. So the idea is that there's different factors, mostly stretch receptors and then chemicals, receptors impacted, osmotic receptors impacted. And so swallowing being voluntary, and really the peristaltic process, which is involuntary in nature, kind of ends about half to 2/3 of the way in the esophagus. Skeletal muscles anatomically, and the transition is roughly between half and 2/3 to all smooth muscle. Once you get to smooth muscle, peristalsis officially takes over. And that's the major way, these alternating ways of contraction and relaxation. It is the way it, and you're going to see when we get into the intestinal area, particularly small and large, more small than anywhere else, we get segmentation, which has a certain amount of back and forth movement, where pure peristalsis is pretty much unidirectional, and a certain amount of mixing from the compression occurs. This is about a combination of mixing activity as well as movement. So segmentation is sort of a variation where it takes, and it's designed to take a little bit longer. I mean, it's fascinating in that regard. I mean, again, that's the frame. Imagine, if you will, and I think I told all of you the same thing. I couldn't eat solid food for about 6 months before having undergone major surgery. That ain't fun. You know, I'm no one to blame but myself for letting it manifest itself like that. So they talk about, to me, digestion is either mechanical or chemical. I don't, to me, it's mechanical breakdown versus, more chemical breakdown are both parts of digestion. The segmentation is mostly intestinal in nature. It's all catabolic in nature. What's the watchword with all of these? Water. These are effectively hydrolytic processes with rare exceptions. The only real exception to that, when we get to it, is lipolysis. We're using enzymes, and it's less water-based because water has less of an impact on a lot of fatty structures. That would be sort of the oddball on this. And obviously, most of the way we're taking this down, there's a certain amount of blood or lymph that we'll get into. And again, fatty products that are, when they're broken down, typically are absorbed through the lymph, though some may or may not be carried in the bloodstream. And obviously we get rid of whatever's left over, along with a variety of other substances, is expelled. They give you a nice chart to look at that. And then this is the anatomical organization not doing it. The only one that is, pardon me, of relevance to us, I think, is probably more about the relationship of the visceral and parietal peritoneum, in the sense that if you remember the mesenteries from anatomy, those are layers of visceral peritoneum that sandwiched within them are nerves and blood vessels and lymphatics that are designed to supply all of these structures. So they're carried to them by that, and they play a pivotal role in their organization. Remember, I always tell that interesting anecdote about, how when you open up the bowel and you run the bowel in surgery, you take it out, you don't have to carefully put it back. It just goes back into its normal position. So when first time I saw it, remember, my eyes lit up like that, because I was just so astounded by that as maybe a resident who'd been a resident for 3 or 4 months. Never having seen that. So that's the mesentery. That's really that visceral peritoneum, all the stuff that's in there. And then we're not going to get too much into distinction between retroperitoneal and not. The liver's the oddball because it's got ventral mesenteries on both sides. That's interesting. It's a sterile environment. Anything that's released into that environment that be construed as non-sterile. And this is where we see gram negatives, with ruptures in bowel, with tumors that rupture tubular structures. They flood into that area. That's peritonitis. That's immediately life-threatening. The classic ruptured appendix is like that. First thing to recall is this. Not so much the anatomy that we're going to, because I do that in anatomy, but is the idea that this is a unit that basically functions autonomously, even though we have overrides. We have the normal tone is parasympathetic, meaning that the parasympathetic tone keeps it functioning. And like you're all sitting here now, our digestion is probably just going the way it normally would. The same is true when you're sitting, maybe a little more active overnight because you're good rest and that system's genitourinary and gastrointestinal are very, very active comparatively at that point in time. Sympathetic is the override to stop it down from fight or flight. Other than that, the parasympathetic tone dominates. It doesn't have to do much because of these nerve plexes. You have intrinsic nerve plexes in the submucosal area here that control that unique mucosal layer, which has the rapidly dividing lining cells, the pockets, which we call pits or crypts. In the case of the stomach, you're going to see that they're pits. We have a submucosa that plays a pivotal role in the absorption and protective process, and that wonderful thin layer of smooth muscle called the muscularis mucosa. They're all controlled by the submucosal nerve plexus. Remember my way of looking at it. Those receptors are designed when food enters to accommodate, whether they stretch, but they provide maximum contact with the food. Because I like to think they embrace that existential relationship I have with food. I eat, therefore I am. And then the other nerve plexus, the myenteric, the big my for muscle, and it's about the consistent finding of circular, then longitudinal muscles. That really is almost like setting the rhythm of peristalsis without the overrides that are there. So again, it's just a series of stretch receptors that can be tinkered with by external factors like sympathetic tone overriding it for fight or flight, or different things that you put in there, chemically speaking, and occasionally the triggering when food passes through, you'll see that it'll trigger areas that are hormonally dependent. We're going to start to see gastric secretions and intestinal secretions that are rich in powerful agents like gastrin, secretin, cholecystokinin, which we'll get to. And particularly now, not just the names, but the roles they play. Okay? So again, when we look at those layers, the submucosa is just that. Think of it as it's designed for one reason, to support the mucosa. We don't have a lot of submucosal layers. That's the unique thing about the fourth layer. It really is the unique construction of the mucosal layer with the three layers, and because that's so elaborate and elegantly designed for digestion and absorption, that we have to have a submucosal layer. Yeah, there's elastic tissue because they go back into shape. Okay? I keep telling you that. I still have a stomach that works, even though they've removed half of it, not once, but twice. So, anatomically, I've got a quarter. My daughter liked the movie. My daughter-in-law said pictures of the kids.
What movie?
Movie with the kids.
Oh.
Kids. Grandkids, in my case.
Oh, can we see?
Later. God, I'm really disappointing Chelsea today.
What did I do?
I'm sorry. Okay. And here the distinction is these all move. Yeah, other than the esophagus, and until we get back down into very limited areas, all of these are designed to move freely. So we call the lining serosa. Serosa secretes, you might recall, a serous fluid where it gets its name. That's really a lubricant more than anything else. Not particularly thick or oily, but just viscous enough to allow these structures to move against, and they do it constantly. If they're not doing it, there's a problem. The esophagus is surrounded by something that doesn't move. It's called adventitia. Those structures that we commented on that were retroperitoneal, small part of the duodenum, a couple of the flexures with regard to the colon. Okay, once we start getting, and then when we finally get toward the end and we get to the anal rectal area, now we don't, it's not designed for movement. So the outer layer becomes something called adventitia. So the whole idea of this is motion. So sitting here now, I said it before, you could take a stethoscope, put it on anybody's tummy, and you hear little binks and clinks and things like that. And that tells you those are normal, we call them bowel sounds. You're supposed to hear them. When you don't hear them, there's a problem. So there's that same illustration we saw before. These are anatomical, the different circulations that are there. Again, from a functional standpoint, this is the key player to me, other than the anatomical arrangement that it's not bilateral and symmetrical. It's not like there's a right stomach and a left stomach. There might be a right and left gastric artery, but they're basically all coming off of single arteries that are designed to supply the single alimentary canal. The oddball, the interesting one to me is the hepatic portal circulation, where we have all of the contents, particularly from the large and small intestines, and to a lesser extent from the stomach. You don't get a whole lot of blood coming out of the stomach. There's not a whole lot of absorption in the stomach. Yeah, all of that blood flows into one vein. So they get little venules. It's called the hepatic portal vein. That is what makes it a portal system is you have capillary beds in sequence. The capillaries in the intestinal organs coming to a vein, then that going into the liver capillary bed called liver sinusoids, where it sort of just percolates through, would be the way to describe it. In the old days before drip coffee, and you see it in restaurants and things, they have percolators. And what that would be is the water would boil, it would start to pop up through typically a metallic or a glass tube and drizzle down onto the coffee, and we do that repetitively over time. Percolator, we all grew up on that, my day and age, before we had automatic drip coffee makers. And it's kind of what the blood does in there, sort of kind of just keeps running through and rushing through, pouring over the cells, and the hepatocytes interact it and process, get rid of toxins, make proteins, all that good stuff that the liver does. Can't live without your liver. Remember what live spelled backwards is evil. It's like I'm giving you an evangelical. Live spelled backwards, evil. Sin spelled backwards is nice. I forget who did those. Somebody did those. Oh, they're silly. Those are very old types of things. I don't mean anything by them,
Did you
please.
steal? Was that a bit?
What?
Someone do is that like?
Oh, that was a bit. People used to do those. Comedy used to be bits that didn't involve swearing or sexual references. I know this is foreign to you, but you had to use those things. So it was sort of situational and jokes and things like that. Every so often you'd make an inference, so you had to infer that. It was the way comedy used to be done. So I mean, they just have, and every so often they would get, some would be a little more toward the vulgar side than not. It's like Rodney Dangerfield gave it, I don't get no respect. You remember him from the Caddyshack days, the late Rodney Dangerfield. So he had that whole thing. There's a guy named Jackie Vernon who used to have an imaginary, we didn't have movies and PowerPoints. We had slide projectors. You go to somebody's house, oh, let's use slides of your vacation. And so he'd sit up there with a little clicker, and you'd have to imagine it. Here I am on my vacation. Here's my wife on my vacation, with me on vacation. Here's my wife and the bear. Here's just the bear. Here I am. The bear took this picture. He'd do a routine like that. That was appointment television for our day and age. We watched the Ed Sullivan Show at 8 o'clock on a Sunday night. First place the Beatles performed, the Stones performed back in 1964. And then everybody watched Bonanza. So they worked. Pretty much Gunsmoke after that. Just saying. So this enteric nervous system, they call it the gut brain because it effectively communicates with each other. There's not a whole lot else to say about that. Those are two systems, the submucosal, and this is physiology, glands and smooth muscle in the line, the mucosal linings. We'll get to the individual organs. And this one is the motility, the movement, peristalsis and segmentation. There's a variety of reflexes that are short and long. Short is the gut brain, those enteric reflexes. Long, autonomic output, parasympathetic, increasing it, not often. Sympathetic, fight or flight, showing it down. All you have to know about that. What's interesting is the provocation of this by different kinds of stimuli. It's not just mechanical, but chemical. And chemical can mean actual chemicals and osmotic levels, osmolarity levels also are in that as well. That's what, so it can be electrolytic levels in that regard, not just necessarily chemicals per se, like gastric. Stretch, osmolarity, pH is the basic key to this. The stomach is an acidic environment. The small intestine is an alkaline environment. We have to take highly acidic contents and rapidly change them to alkaline in such a way to avoid damage. When that doesn't happen, what happens is what happened to me. Okay? If there are problems violating the lining in the stomach, that acidity causes breakdown in the underlying tissue. We have a famous word for it, ulcer. An ulceration is a break in integrity. Diabetics get ulcerations in their skin. So an ulcer can be internal or external. If you have somebody where the acidity, where there's a failure in the pyloric area, the pyloric sphincter, and you have acidity pouring out too quickly, you get a duodenal ulcer. When do we see that? Not when you're eating, but usually 20 to 30 minutes after you're eating. So those are ways that you diagnose that based on those types of things. So different kinds of products and substrates work on it. So all the mixing and movement activate or inhibit certain, and those changes, certain chemicals will cause other chemicals to be released or cause them to stop being released. That's what we're going to get into. So this is all introductory stuff. So again, the intrinsic and extrinsic controls, the various hormones, this is all anatomy and we're not doing it because we did it already. All that type of stuff I don't care about because we did it for anatomy. Terms that I use as I go through this and sort of narrate to myself. Bolus, I talk about the bolus. It's like when you inject something into an intravenous line, it's called a bolus. So a bolus is typically a unit of fluid or fluid-like materials. So it's the bolus of food is that wad of food, that terrible bite of a sub I had from Sheetz last night. It was bad. They're off my list for at least a week.
Just 1 week.
That's it.
You're forgiveful, man. Forgiveful.
I forgive and forget. Not doing that. Not doing that. Not doing that. Glands. I'm so glad. Saliva, more functional. Yeah, chemicals for taste. Starts the formation of the bolus. First note. What do they produce from the salivary glands? The first enzyme, salivary amylase. It starts to process starches immediately. Your tongue starts the processing of fat by way of what's called lingual lipase. So we don't touch proteins till they get in the stomach. So we're not talking about major processing. It's just starting to break down starches and a little bit to start to break down the fats. We'll keep it non-specific. Most of it comes from those three glands, parotid, submandibular, and sublingual. The parotid and the submandibular are mostly serous, more about the saliva. The sublingual is a little bit more mucus, so probably a little bit more pattally oriented, I would think. Not going to go into where they are. Parotid is surely the largest. About that, right overlying the masseter muscle. You remember, interesting, because the only reason I recollect it so well is my mom had what was called a mixed tumor in there, but thankfully it was benign. She had that. I'm going to tell you when she's probably about 72, 73, because my sister and I came in a long time ago. Serous and mucus cells, about all I have to talk about. Different things that are there. These are problems that it's interesting that lack of moisture really is a problem because it plays such a pivotal role immunologically. Saliva is just such a really, think of what's in there. You have lysozyme in there that attacks gram-positives. You have those defensins, which are antibodies. We talked about those. So it overlaps, and something I'll ask you about undoubtedly on this third test, which you're not going to take it home. I love Sjogren's syndrome. You don't see a lot of that. Remember I told you I had that very famously? Venus Williams has that. That's one of the things that has affected her later in her career, not rather than earlier. Not worried about all that stuff, really. We don't have to go through it. Just what it does. Make about 1.5 liters a day, moist, parasympathetic active, okay? And we salivate for a lot of things, and it's teeth, and I don't do a blessed thing about teeth. I don't do teeth. Teeth. Moving on. Not a whole lot with the pharynx. We talked about it already in respiratory, 3 areas, what they're immediately behind. Basically, in our case of digestion, the pharynx is just about swallowing more than anything else. I think it's much more of a player in respiratory, because once you get into effectively, you're just leading your way to the esophagus. So there's not a whole lot. The muscles that allow it, it's like an open funnel. The muscles are behind and along the sides. They're voluntarily controlled. Those are the pharyngeal constrictors, 9th cranial nerve. And so effectively, the esophagus doesn't really have a whole lot going on to it unless there's a problem. And the only problem that really is impactful digestively in the esophagus has to do with gastroesophageal reflux disease, where the cardiac sphincter, the end of the tube, where it narrows and the muscles increase to create effectively a valve, an involuntary sphincter called the cardiac sphincter because of its proximity to the heart, and that area that's named to the stomach for it, the cardiac area of the stomach, where it pierces the diaphragm, inexplicably sometimes can weaken. Certain things can add to it. Alcohol, certain foods, hereditary factors, aging factors. Sometimes being effectively born with defects in it can occur. It can have, my dad got, and again, that weakness can sometimes be demonstrated with called a hiatal hernia, where it begins to pouch up through the diaphragm. The area weakens. It can happen in babies. It can happen in older individuals as well. So there's a lot of that goes on. Most of the time, the reflux disease itself, I think, has a lot to do with certain combined factors. Drinking, smoking, different kinds of foods that you eat. Some people are just very, very sensitive. I still have that. My problem is medication related. There's a big relationship between damaging the lining and causing irritation and damage to the area, and to be sort of reiterate the point, for non-steroidal anti-inflammatory drugs. So you can read that as ibuprofen, naproxen, whatever. Okay, so it's all about protecting you from reflux. It has the layers, that's fine. The whole idea is to transition Stratified squamous is not designed to deal with the acid, where the simple columnar, the hallmark epithelium of the digestive tract in the stomach, particularly because of basically the nature of the secretions are such that they're rich in bicarbonate to neutralize it. So even though the acid is there, there's a layer. There's a lot of tight junctions in that lining, so it can't get through the acidity. And most of the secretions that are in there are rich in bicarbonate to offset that degree of acidity. So again, the only thing the glands there do is effectively is a lubricant, nothing else. You can see anatomically, we talked about this, very expansile. And that's a really good illustration of the transition that you might recall as well, where here we see stratified squamous non-keratinizing. And here you see a classic gastric pit. And then what's it lined with all along? Simple columnar. Da, da, da. Big problem here. That's what it is. This is really the big cause. Esophageal cancers have a very bad prognosis. As we see somebody who's had an ulcer disease, when ulcers perforate or effectively rupture through, very bad prognosis. Esophageal carcinomas come from really prolonged reflux disease that's not addressed, those kinds of things. And they talk about different phases. I don't really do this part either. It's just kind of show you the food passing. And really, it's the stretch receptors that eventually will open and allow this to move the food in to the stomach, as you can see by those illustrations. Which brings us to the stomach. End product, chyme. CHYME. After food enters a stomach which is relatively small, normally, we're talking about a couple of ounces of volume that can expand effectively to a gallon. And again, by that wonderful idea of folding that we talked about before, where you see ridges, and the ridges not just forming because of it folding, but the ridges maintain themselves unless it's completely expanded and become a surface, because what kind of digestion happens in the stomach? Mechanical. It's basically a giant mixing bag that is designed to create the chyme. It takes the fluid, it takes acid. Now you're going to see we have the introduction of the first proteolytic enzyme when pepsin is activated. There's a little bit of lipase coming to the party as well. Okay. There's gastric lipase and gastric-based proteolytic enzyme in the form of pepsin. There's water, hydrochloric acid, and voila, we get this, turns what we're bringing in to a pasty substance that really is, it eventually becomes chyme, rich in acidity, very low in pH, that squirts out in tiny little squirts of about a half a teaspoon to a teaspoon into the large intestine, because if it didn't do that, it couldn't be neutralized fast enough, and it would create damage to the lining. Okay, so, and that's anatomical, the cardia, the fundus, the dome. Dome-shaped areas we call fundi, the body, and then as it narrows, the antrum and pylorus, you remember that, and there's another valve at the end. That's what it looks like. Remember, you have a third layer in here that designed underneath an oblique layer, so it does that over and back. I always use the washboard analogy. It's there. It's anatomical. That's anatomical. Blood supply. Okay. Now we get to what's left of the physiology we're going to do. I don't know what they're talking about. There must be a sign. Send me text messages today. Yeah, I'll get back to you sometime next year. So, mucosa, simple columnar, alkaline mucus. Underneath, it's so rich in bicarbonate, okay? So that fluid, and what you're going to see, it's almost like the analogy would be if you had something and you just punched a series of tiny little pinpoints into it all over. So the stomach is just replete, just filled with these indentations like you saw in that micrograph called gastric pits. Those pits effectively are the glands, and effectively the pits of the opening, the glands are the cellular structures you see here. They're everywhere, okay? And again, they don't go beyond, they're all located within this area of the mucosa. And then you recall, we looked at it anatomically. You have the regular cells, the simple columnar, something called mucous neck cells, we don't know the function of, and then the intriguing part that we're going to get to as we conclude today. Parietal cells, there are two things they do that are extraordinarily important. They are proton pump cells. They're the start of hydrogen ions that, along with the chloride shift, are going to create, remember we talked about the chloride shift a little bit earlier with respiratory, create the hydrochloric acid for the stomach. They also make intrinsic factor that's essential for absorption of B12 gastrointestinally. If you don't make that, then you have to find a way to get that into you, either by injection or some other means. As you get farther down, the chief cells make and this, we're going to be filled with this for the rest of these lectures, what are called zymogens, Zymogens. Zymogens are enzymes in precursor status. So the ogen means it's inactive or precursor. So these produce pepsinogen. And the pepsinogen, in the presence of hydrochloric acid and what it produces, the combination pepsin, serve to activate this, the first of the proteolytic enzymes, pepsin, to start to break down elementally. We've got proteins, we're basically just chopping up into shorter subunits polypeptides. And eventually we have series of these that break them down in the small intestine to what finally is absorbed, which are amino acids. So we go back to basic biochemistry. We start with proteins, we chop them up, and we turn them into amino acids, and amino acids are finally what enter. And then all the way down, that little guy in green is the fascinating piece. It's called an enteroendocrine cell. Entero because it's in the enteric or the digestive tract. Endocrine because that's what it does. It makes a hormone. Interestingly, the hormone, it makes more than one. The principal hormone it makes is called gastrin, so we sometimes call them G cells, capital G. And that gastrin, what it does is it's, because it happens as soon as food enters, it actually signals the other cells, we've got food, make more gastrin. So it's almost like an autocrine kind of thing. It's working on the same area. It's produced by the stomach and works on the stomach, along with other factors that have hormonal type effects we'll get to. So this is sort of the summary. Hydrochloric acid effectively is secreted once we have, because effectively they're proton. When you see somebody who takes a proton pump inhibitor, like the Prilosec I took, this is what it works on. But we need hydrochloric acid for all of those things, to activate the pepsin, to break down plant cells, and more importantly than anything else, it's bactericidal effects. And then the intrinsic factor. So chief cells, pepsinogen, and the lipases we talked about before, that really start to are a little bit more efficient than the lingual lipase. The enteroendocrine cells, so they have a true hormone, gastrin, that works on the bloodstream but works immediately on the stomach. Somatostatin, which has paracrine effects, means it works on neighboring cells. And so somatostatin, which is sort of like the way I would describe it, is it limits the activity of somatotropin, which is growth hormone. because typically when you're eating, your body is shifting over to your utilization of insulin as the activating factor for ATP synthesis. The idea is to use carbohydrates and carbohydrate-like substances as the substrates to make ATP. Growth hormone uses fats. That's why growth hormone has all those neat things that it does. So we're going to slow down growth hormone. Serotonin, same guy from neurotransmitter land, has a variety of usages in the clotting cascade, and it has paracrine effects along with histamine in the stomach. So if you know somebody who has stomach ulcer disease and they take something like Tagamet, it's called an H2 blocker. They've had some problems with these. They had to pull some stuff off the market because it was creating problems. Those are histamine 2 receptors. So basically, the histamine here activates digestive processes along with serotonin. It's interesting that agents, these are both effectively neurotransmitters, have different effects in the bloodstream, have different effects in connective tissue, have different effects. Histamine triggers anaphylactic shock, triggers asthma. Okay, serotonin, maybe the most complex of all the activities based on the receptors of all the neurotransmitters. Serotonin, which causes blood vessels to spasm in the blood. So it depends on what they're contacting. That's the unique part of understanding the advanced aspects of physiology. When I teach this to AP2, it's basically, it makes serotonin and histamine. Remember that. That's and that's the interesting thing. Chief cells make the pepsinogen, the hydrochloric acid converts that as the catalyst to make pepsin, chops it apart, as it were. And then the pepsin positively feedbacks to make more. I love that. So the barrier, bicarbonate rich, tight junctions, a big player, rapid replacement, problems that occur with these different kinds of ulcers, either called peptic or gastric erosions, which I have. We don't even address the Helicobacter pylori because it's not true. Gastric cancer, I might agree with. Big players, caffeine, nicotine, aspirin, those types of things really play a role with it in alcohol. And we'll stop there. Thanks. See everybody Friday.